Good evening, everyone. Welcome you all to Oncology Classroom evening session. This month, we are going to discuss different topics from lung cancer. And today we are having a very interesting talk on pathology and molecular aspect of lung cancer in the era of NGS. This talk will be delivered by Dr. Aparna Dhar, who is the head medical genetics and genetic counseling at Core Diagnostics India. She has been a trained medical geneticist and genetic counselor from Mayo Clinic College of Medicine and University of Glasgow, and she has more than 10 years of experience in this field. Thank you, Dr. Aparna, for accepting this invitation. A very warm welcome to you for this evening session. May I now request you to take over this session and start your presentation. Thank you so much for being with us.
Perfect. All right, great. All right, good evening, everyone. Thank you, Dr. Dodal, for having me here today. And thank you for giving me a topic, which I think is absolutely fantastic in today's day and age, because what we're starting to see essentially is the way, medical oncology has changed, and primarily in the field of lung cancer. So what we're starting to see is this beautiful overlap, this beautiful amalgamation of anatomic pathology with molecular genetics, and we're seeing that it's playing a very crucial role in our patient care.
I'm sorry, Dr. Aparna, there is some flickering of your screen. Can you please stop and reshare the screen?
Oh, sure. Just, oops. Okay, I've stopped sharing. Okay. Can you see the screen now? Is this better?
Yes, better.
All right, great. Thank you. Sorry about that. Right, so what we have seen, I'm just going to close. Sorry, just give me one second. Okay. Right, so what we do know is that we do have a problem when we think about lung cancer, and it's specifically that it's a very silent disease. And by the time the patient
I'm sorry again, this flickering is coming back, yeah.
Oh gosh. How do we do this? Let me just switch off my video. Maybe that's creating a problem. Let's try it that way. I'm so sorry about this. Sure. This is what I call first world issues. Okay.
No, it's still there.
It's still flickering?
Yeah.
That's very, very odd. Okay, just give me 1 second, right? Sorry about that, everyone.
Can you please email your presentation to me? If possible, I can just download it and start sharing from my end. Is there an option?
Sure. Yeah, that's possible. That's possible. Just give me 2 seconds and I will have that done. Sorry about this, everyone.
So please allow us for another 2-3 minutes.
रिकॉर्डिंग पे लगा है अभी हट जाएगा।
Dr. Aparna, can you please unmute yourself?
Yes, I'm just sending it to you. I'm just upload. Sorry, just give me 2 seconds. It's going. Okay, I've sent it.
All right, just give a moment. Yeah, I just got the PPT. Just a second, few seconds only. Is it visible to everyone?
Yes, yes.
Great.
All right, thank you. Sorry about that. Technical glitch. All right, let's get started. So like I was saying is that in today's session, what we're going to be talking about is lung cancer. So one of the biggest challenges that we do face with lung cancer is that it's specifically a silent disease. And by the time the patient actually presents to their doctor with symptoms, and by large, they've already got an advanced disease, which means that the disease has spread out to the lungs and to the other parts of the body. So by definition, you would say stage 4. Thus making it incurable. So obviously we are looking to improve in this area, and we've come a long way from the way we treat our patients. And the rest of this talk will particularly be about patients with advanced or metastatic lung cancer, and specifically the type called non-small cell lung cancer, NSCLC. This is the most commonest type of lung cancer that we can see under the microscope. Next, please. So back in the 1990s, we were actually still discussing, and the story goes, I'm not going to go way back, but I'm going to go to the 1990s. We were actually still discussing if chemotherapy actually had any role whatsoever in the treatment of lung cancer. So this was an interesting, a seminal study that was published in the British Medical Journal. And what they did is they pulled all the published studies. So essentially you start off with, let's say, 100 patients, and you monitor them over a period of 24 months. And as each patient dies, the curve drops a little bit. So you look at the median over here, and you see that the patients that did not have chemotherapy versus patients that had chemotherapy, the survival of patients with chemotherapy was just under 8 months. That's where we were in the 1990s, and absolutely appalling statistics when you compare it today. So next, please. By the early 2000s, what we decided was that, chemotherapy was the treatment of choice, and we played around with a number of regimes and identified that honestly, it didn't matter which particular cocktail of chemotherapy you gave, the outcome was fairly similar, fairly poor. And it just had a median of what? I think it was 7.9 months of which a patient would survive with treatment. Now, next, please. Around the same time, we had a number of publications, and particularly the Science magazine and Nature magazine, and those top journals were reporting the first draft of the Human Genome Project to us, the first reporting to us as to what the sequence of us as human beings is. Because if only we could understand what the normal human genome code is, can we actually begin to appreciate what the cancer genome code is. And as we all know, that while it's ironic and it's kind of funny if you think about it, that whilst the cancer is derived from the human being, it is by and large very different, particularly in lung cancer, from the human that it's derived from. And this prompted a very interesting title in the Time magazine. It was a front page that said that with this knowledge, could this actually prompt drugs of the future, help design based on the DNA of human beings? Thought to be a pie in the sky back, this was back in 2000s. We couldn't even think about targeted therapies. But here we are, and today what I'd like to demonstrate to you is that we've actually implemented this very, very successfully in routine care. So lung cancer itself, specifically NSCLC, is not just one disease. It's often thought to be that, or when you it's often thought to be that, like next please, sorry, just realized I said that. But actually, when you look at the genes and the genetics of lung cancer, it's a group of different mutations. These are diseases that are essentially encoded in different patients, and the disease is driven by, if you see over here, they could be driven by ALK, they could be driven by KRAS, EGFR, HER2. So when a patient comes to you, next please. So if you look at, oh, sorry, go back. My apologies, go back. If you take a look at these patients, and you look at them, today when you write a prescription for a patient who is a known case of NSCLC, I don't see my doctor writing NSCLC. I'll get, oh, he's the EGFR type, or he is, he's got an ALK fusion, or he's got a KRAS. And this is how we've actually started to define these patients. So while we were learning and understanding all these various genetic aberrations, the data that we got from the human genome, we parallelly decided, looking at that data, that there were possible therapeutics that could be invented. And these were specifically what we call molecular targeted therapy. Next, please. So the tyrosine kinase inhibitors, this particular pathway, the TKI pathway, this revolutionized the way we treated our patients. This just completely changed the face of lung cancer therapy. So when targeted therapy is taken into the blood stream, they affect all our cells. So this is a cell. This can also be a cancer cell. And in the center over here, you see you have a nucleus. In the nucleus, you have a DNA. So tumors that are mutated, or as I like to call them, addicted to the drive of an oncogene mutation, the mutations in the nucleus, it encodes for an abnormal receptor, which is essentially over here, this blue receptor, which automatically gets switched on. It does not need the outside signal, which is the pink signal over here, to tell it to grow or to divide. So what happens is, because it's automatically switched on, it's leading to uncontrolled proliferation of cells, which is leading to obviously a tumor. So what this targeted drugs function is that it goes to this blue receptor and it goes and switches it off. It automatically switches it off, and the growth signal to the cancer cell obviously gets disrupted and potentially kills your cancer cell. This particular signal was discovered, I think, back in 2004, and in 2007 there was a very interesting study which was conducted in the US, which proved that patients with a mutation, if they are given molecularly targeted therapy, if they're molecularly matched, they responded way better than the one-size-fits-all chemotherapy. They had a better PFS, which is progression-free survival. They had a better overall survival. So it was while this may seem brilliant, it's very important to note that if the genetic aberration is unknown, targeted molecular drugs will not work. And then at that particular point, you may just be better off with chemotherapy. Next, please. So like I said earlier, we've moved on now. We today have molecular stratification, because if we take our patients with abnormal mutations, pathogenic, disease-causing mutations, we can actually work out the differences between the different type of mutation. So what do I mean by this? So if you look at this over here, look at this particular case, we've got an EGFR, L858R mutation, or an exon 19 deletion, one of the most common mutations that we see in lung cancer. And if we give them an EGFR inhibitor, that inhibitor will be great. We have the data for it. And if we keep that disease under control, so for what, maybe a year, if the patient's lucky, maybe 2 years, or if the patient's super lucky, 3 years, But you and I know that this is going to grow again. And when it comes back again, we're going to go in, we're going to do a rebiopsy. We're going to send the rebiopsy for molecular profiling. From the molecular profiling, we may be able to identify another mutation, let's say a T790M. And guess what? There is another great drug that actually switches off that function, and we're now buying the patient, fingers crossed, hopefully another 12 to 18 months. And this has revolutionized the way we treat our lung cancer patients. So you're biopsying at presentation, you're doing molecular analysis, treatment, you treat them with molecular therapy. On progression, you do a rebiopsy. In the case where a rebiopsy is not an option, you go in and you do a liquid biopsy, which is you take a blood sample and you isolate the circulating tumor DNA from it, and then you again do a molecular analysis, you retreat the patient with match therapy, and so on and so forth. And a patient can essentially go on for years without chemotherapy. Next, please. So what you see over here, these are incredibly powerful agents. And the critical issue here is actually to understand the biology of these tumors. If we actually understand the biology of tumors, the oncogene addiction process, then we can match this particular drug to the particular genetic aberrations and hopefully get good desired, the results that we want for our patients. Next, please. I'm going to be talking on this in a little detail a little bit later in my talk. So what you see over here is a snapshot view of the NCCN guidelines, which is the recent ones of 2020. And they are recommending, and again, the guidelines guide, they recommend, and one thing that they are highlighting, be it for the NSCLC type, be it for the squamous cell type, is EGFR. I want to use the word it's mandatory and sort of recommended. I know it's controversial when you say that, but I think it is so important that at least a minimum analysis of EGFR, ALK, ROS1, BRAF, and PDL1 be done. And again, this list is static. If it's not static, it goes on changing. So if I look at this in 2018, or I look at it in 2019 or 2017, while EGFR, ALK, ROS was constant, we now have BRAF, we have PDL1. And as and when we find out more driver alterations, and along with that, more importantly, you get more drugs approved. Next, please. As we see over here, that while yes, EGFR, ALK, ROS1, KRAS, while these are over there, they're very common. We're starting to recommend even MET upfront in the case of our patients because we've got FDA approvals for therapy. NTRK, PDL1, you've got your MET amplifications, you've got TMB, you've got MSI, the NTRK, oh, sorry, I did say NTRK. So the list, as you see over here, it's never ending. So next, please. You've got so many biomarkers. I mean, how do you proceed? How do you as oncologists, how do you as treating physicians proceed? How do you know which platform, which panel of choice? And we are spoiled for choice in India. Next, please. So there are different methodologies and specimen types that are acceptable in the case for at least these primarily, for these particular biomarkers. So in the case of EGFR, we look at EGFR, we look at KRAS, we look at your BRAF mutations. Again, as you see over here, I'm talking about biopsies, I'm talking about ctDNA, and we use a technique called real-time PCR. And we can use NGS, we can use ddPCR. So there are various platforms. You've got FISH, which is fluorescence in situ hybridization. You've got IFC. So biopsy, ctDNA are my main, specimen types that I would like to analyze for my patients. I do prefer this in the lab. Apart from PDL1, I think for everyone else, we do try and accept cell blocks because, as we know, tissue is an issue in the case of lung cancer, and sometimes a biopsy is not very easy. So in cases like that, we do allow, if I could say, a cell block, but it's not really the recommended choice. It's a push come to shove. I don't have an option. I need a biopsy. In those cases, we will accept a cell block. Next, please. So I'm going to talking about biopsies, and as I mentioned earlier, that when your disease progresses, we also have, when biopsy is not an option, we also have the option of a liquid biopsy. And in the case of lung cancer, tissue is such an issue that sometimes the tissue sample is limited. You can't access the tumor site or the metastatic site. In cases like this, which makes it very hard to get a diagnosis, and as we know in the realm of lung cancer, it's very, very important to do the molecular profiling, because you obviously want to give your patient targeted therapy versus chemotherapy. And that's where I think liquid biopsy becomes a very beautiful, a very beautiful platform, a very beautiful specimen of choice in this particular arena. So a common confusion. So what are we looking for when a patient comes in for molecular profiling using blood, essentially normal blood, like how you take a blood test, a normal blood as your sample of choice, as your specimen of choice? We're looking at something called circulating tumor DNA. Now, ctDNA and CTC, which is circulating tumor cells, are two very different entities. Circulating tumor DNA is essentially when in your tumor, cells get lice, cells die. When those cells die, those tumor cells die, the cell breaks and it releases the somatic DNA into the bloodstream. That is the DNA we're going to be analyzing. That is your circulating tumor cell DNA, because it is the DNA breaking directly from the tumor site and going into the bloodstream. These circulating tumor cells are essentially an intact tumor cell which is in the bloodstream, and we tend to use that more it is still in a research setting, and we tend to use that more from a screening perspective versus from a diagnosis or a profiling perspective. So why do I like liquid biopsies, and why have I mentioned it as one of my platforms of choice and specimen of choice? Is because in the case of metastatic disease, and especially in lung cancer, albeit yes, it is non-invasive, I think one of its biggest advantages is that you can do tumor profiling. You do understand, you can actually use it to monitor tumor response, and that is by, again, as I told you, it's a blood test. It is non-invasive. You're able to look at the variant allele frequency of your mutation, of your gene of choice, and see its variation. Is it going up? Is it going down? If the mutation, the percentage of the mutation is decreasing, it means your patient is responding to therapy. So instead of sometimes just waiting for, I know it's an expensive test, I will give that caveat, but in cases, instead of waiting for radiological reports, I sometimes think that just looking at that, variant allele frequency can help in monitoring your disease. It can also give you a premonition should there be any type of resistance. Now, I'm going to be talking about this a little ahead of my talk, but in the case of EGFR, like our patient had, the one I spoke about earlier, had an L858R mutation, but when the disease progresses and there's a resistance in the form of, let's say, a T790M, that is something that can be caught super quick on a liquid biopsy than actually waiting for a patient to progress and to present with a progression radiologically. And most importantly of all, tumor heterogeneity. And tumor heterogeneity, I cannot stress enough as to how important it is, because as the disease progresses, it's mutating, it's constantly mutating. So to actually see the mutations in real time, I personally feel that liquid biopsy is an excellent platform to think about. Next, please. So So I'm going on and on about all this EGFR, ALK, ROS1, MET, and I'm just going to very quickly shed light on these mutations. I know everyone's aware of them. Everyone's aware of these biomarkers. They've been around for quite some time. So as we know, EGFR is possibly the most often we've seen in patients who are non-smokers. It does seem to have a bias towards female patients, and of course, it is correlated in the presence of adenocarcinoma, but you cannot just limit it. You can't just limit it to adenocarcinomas, as I showed you in the NCCN guidelines. You tend to see them in the squamous cell type too. And there is also a population bias towards the incidence rate of EGFR mutations. So all the earlier studies, yes, were done on the Caucasian race, and from there we learned the incidence rate for EGFR was around 10 to 12%. Here's the interesting fact that when we started doing these studies in the Asian, in the Oriental race, and primarily in the Asian race, and if you just look at the Indian subcontinent or the Indian population, our incidence rates for EGFR were as high as 30 to 35%, and there are some labs and some hospitals reporting close to 35 to 40%. So there seems to be a population bias. It is possibly one of our most commonly seen mutations. And again, over here, when we are using standard of care, which I showed earlier, which was real-time PCR, in the case of EGFR, we are looking for hotspots. And these hotspots are I use the word hotspots, this is actually inaccurate, but we're looking for exons 18, 19, 20, and 21. Exon 19 and exon 20 being one of the most common mutations that we tend to see in our patients. Now, when I say that I'm looking at hotspots or I'm looking at just certain mutations, it means I am not looking at the entire gene. I am just looking at from the entire coding region. Let's say there are 40 coding regions, and out of these 40 coding regions, I'm only looking at 4 coding regions where I know majority of my patients fall in. And in doing so, what happens is there is a potential of losing patients who could potentially benefit from targeted therapy because I haven't screened for them for the other, I haven't looked at the other coding regions. And I think this is where, while real-time PCR is the gold standard, it is the established standard of care, I think it's at times like this, with the kind of data that we have, we're starting to reevaluate and see, should we really just stick to real-time PCR? Is there another platforms like next generation sequencing that can actually help address and increase the cohort of patients that could benefit from that could actually benefit from match therapy? Now, if you look over here in the case of ALK, ALK in the beginning used to be done by and large by FISH analysis using, I think what was called, if I remember well, was the VISES dual color break apart probe. And this is the FDA approved version that we have. And now we even look at IHC, which has been approved for ALK, but the caveat in this is it is only approved for the D5F3 clone on the Ventana platform. I'm actually surprised I remember that. It's actually used for that particular platform. And again, in this case, while we do an IHC, if a patient is negative, it is advised to run a FISH and reconfirm on FISH if the patient is positive or negative, and then only treatment is administered, and then only you can actually call out if a patient is ALK positive or ALK negative. Now, the one downside in this is that when we're looking at the fusions, we're looking at the ALK with the EML4 fusion, which I guess is the most common fusion, but we are tending to lose out on all these other fusions that I've listed over here. We're going to lose out on those SNVs, the single, the SNVs. And again, over here, a patient could potentially be losing out on therapy. Next, please. Over here in the realm of ROS1. Now, a lot of labs, and I know we do it ourselves, is that we're starting to use IHC as a platform, and we use the D4, D6 clone, which again is on Ventana. And the main caveat over here, and it's very important that you know, ROS1 via IHC is only to be used for screening. If a patient is positive on ROS1, it is mandatory. It's in the guidelines that you have to go in and do a FISH, because on IHC, we have seen that while a patient may be positive, IHC has an increased chance of having a false positivity rate, and that's why it's mandatory, be it the FDA approvals, be it the NCCN, the ESMO guidelines. Everyone recommends that you do confirm the status of ROS1 using FISH or obviously NGS. Again, in the realm of FISH, as you see over here, I just realized my picture is completely upside down. You have the CD74 with ROS1, and this is the most common fusion that we tend to see. But along with that, you're also you're again losing out on so many other structural changes that from which a patient could benefit. Moving on to BRAF mutation. BRAF constitutes for not more than 2 to maybe 3% of mutations in the case of NSCLC. Again, there's no population bias per se. It's a very generalized thing, and I think this is what we see in our Indian labs. This is what's being reported out from Asia, the Middle East, US, Europe, etc. And again, it's very important in BRAF mutations to be wary of the fact that only and only in the case of a BRAF V600E mutation, only in the BRAF V600E mutation, can a patient benefit from a combination of a BRAF and MEK inhibitor. So if you get a BRAF V600K or you get any of the other alterations that we see in BRAF mutations, your patient with NSCLC is not going to respond. Next, please. MET. Again, who would have thought about MET? You know, we were very familiar with MET, exon skipping, exon 14 skipping mutation, commonly seen, targeted therapy, crizotinib, etc. But now when we look at MET, there's a lot of data that is coming out that in the case of EGFR, we're starting to see MET. Yes, it's not as large as a resistance mutation in the case of T790M. But again, I think it's very, very important to look for a MET mutation because we are seeing it with EGFR, and there is targeted therapy available to avoid an unnecessary resistance and progression in your patients. Now, one thing I do want to highlight, and this is very, very important in the case of MET, is the reporting of MET. MET is reported either by FISH or you're going to be using NGS. In the case of FISH, it is very important, like let's use an example here of MET with CEN7, which is essentially the centromere 7, and when there is a fusion, when there is a translocation that happens over here, the ratio between the MET and the CEN7 signal has to be greater than 5. And it is very, very important that when you are reporting this, and when you do see those reports, that your lab follows these guidelines. This is from CAP. This is AMP and CAP, and actually everyone recommends this, that the ratio has to be more than 5, because only when there's an increase in the level of gene amplification does it carry any sort of prognostic or stratification value. So again, a very important thing to note. On the other hand, you have the RET mutation. Yes, it does have a response to selpercatinib or cabazitatinib. These are so tough. These are like tongue twisters. You know, you've got mutations over there. But again, when you use FISH over here, even the smallest, even a one, even the slightest, the smallest amount, anything that is showing an aberration is considered to be RET positive. The patient has a mutation, and you can give therapy. Versus, you know, if I'm going to compare it to MET. Next, please. So what you see here is a pie chart, which is essentially highlighting all the biomarkers, the somatic aberrations that we see in the adenotype of NSCLC. I just spoke about the most common ones that are there in the guidelines, but apart from that, there is a plethora of these that are available. So KRAS, I didn't speak much on KRAS, but KRAS is where we see, is very common, particularly in our smoking cohort. And while yes, there's no targeted therapy, it does give, it is a poor prognosis if a patient does come positive for a KRAS mutation. And apart from this, there's also a variety of somatic aberrations. And if you note, I'm calling them somatic aberrations. I'm not calling them a mutation. And the reason is that because some of these are fusions, there are a variety of so many structural variants that are easily druggable by a variety of drugs, and we can actually treat them. Next, please. So when I'm talking about all these genes, why do I think, and this is my humble opinion, why do I think next generation may actually be a good platform? And especially in this era of precision medicine, how is it actually benefiting us? Next, please. So I'm not going to belittle and say the standard of care is not good, be it using real-time PCR, real-time PCR, FISH, IHC. No, they are really good platforms. There's a reason they're called the gold standard, but they do have their shortcomings. And so while we're using these standard of care techniques, what you're just seeing, and I like using this example, is that you're seeing a tip of the iceberg. And even at the tip of this iceberg, you're getting a limited view. You don't get a 360 panoramic view of EGFR, ALK, ROS1, BRAF, HER2, MET. Or, you tend to miss out on all these other mutations also, which are submerged underwater. And yes, when you look at them, you're going to tell me, what is she talking about? They're not even targetable therapy. Like, why do I care about these mutations? Because interestingly enough, these mutations tell you the story of the tumor. And a very nice example I like using is TP53. TP53, yes, it's not actionable, but when I see a TP53 in conjunction with an EGFR mutation, I know my patient is not going to have the response that I want. It's going to be a partial response because TP53 inhibits it. RB1 in the case of NSCLC is an indicator that my patient's complete histology is changing. It's going from non-small cell to small cell. There's a small cell transformation happening. And these are very, very important key points. And you know, you want to look at this and get the whole picture so you can treat appropriately. Next, please. And I learned this the hard way. And I think the whole thing with NGS boils down to physicians, is that physicians, you obviously want that information early and you want it accurately. And the reason for that is that we know patients with metastatic disease, the PFS gets shorter with each subsequent line of therapy. And you know, in turn, this decreases the options to your patients. So you want to use the best therapy early, but would also like to switch therapy early if it's obviously not working. And NGS time and again has proven to be a reliable platform to help address these concerns. And it's also had brilliant concordance with your standard of care. So obviously it increases your reliability. So let's look in the era of 2020, next please. I am starting to see that there is an increased reliance on next generation technology in our clinical practice. All too often, your workflow looks something like this. We get a tumor sample from the patient and we send it off somewhere where it gets put into, let's say, this black box where something mysterious happens, and as if by magic, a report gets generated. And while I say this half in jest, considering the differences in NGS methodology, it can actually have important consequences for the downstream interpretation in clinical practice. So for the next few minutes of this talk, what I'm going to be doing is I'm going to make the contents of this little black box a little more accessible. Next, please. So let's start off with the very basic observation. This is a workflow that any lab, anywhere you go, any platform you use, this is what the NGS workflow looks like. You start with genomic DNA, which is then isolated to create a library of DNA fragments. And by the term library here, what I mean is you just make adapters that are added to the ends of the fragments and you make them compatible with your sequencing machine. The sequencing machine then converts the nucleotide biological information into digital information in the form of what we call these large VCF files that consists of reads, and those reads are then processed through various computational analysis, various bioinformatic pipelines to help define these genomic aberrations, these genomic variants. Next, please. So what you see, what you see over here essentially is a beautiful snapshot view of what happens in a lab. So the sample comes in, it could be either a blood sample, as we learned, circulating tumor DNA is an option. You have your normal, what are these called? Your paraffin and blood, your formalin, your PPL, Jesus Christ, your blocks. Sorry, it's been a long day. You have your blocks, and from these, you isolate your somatic tumor DNA. You get your DNA extraction. It goes in for library preparation. And this is a very, very important point, this target enrichment. So remember I spoke about these adapters? It is at this particular point where we define if this is going to be your 5-gene lung cancer panel, is this going to be a 70-gene comprehensive panel, or is this going to be a, I don't know, the 300 plus odd gene foundation medicine panel. It is at this point that you add adapters and you actually segregate and say, these are my genes of interest. Once you've done that and your genes of interest are amplified, they're put into the sequencing machine where they get aligned with a reference genome. Remember, the Human Genome Project gave us access to all the data with respect to the human genome. It gets aligned over there. We start doing a variant call. Now, in the case of somatic mutations, we use COSMIC being the most common database where we go back and we cross-check and we cross-reference to see that within the AMP guidelines, does this mutation and ACMG guidelines, do these mutations actually qualify as pathogenic, which means disease-causing? And only once that there is enough substantial data between the COSMIC databases and the bioinformatics, the information, the reads that we get from there, once there's a correlation, a report gets generated, which means that all that biological information has become something that you and I can understand and can implement into our clinics. Next, please. So yes, like I said, that I'm not going to belittle the standard of care, which is your real-time PCR, which is your FISH, which is your IHC. But I think in today's day and age, one of the reasons a lot of people used to be hesitant in the realm of NGS was because, oh, it's really expensive. But today, thanks to tie-ups with PSP and just with the overall demand of next-generation sequencing, it has become mighty cost-effective. Now, again, if you see your, if you had seen the NCCN guidelines, they speak about how you test the EGFR. EGFR is negative, then you go to ALK. ALK by IHC is negative, then you go on to ALK by FISH, then you check for that. If that is negative, you go on to ROS1. From ROS1, you may go to PDL1. From PDL1, you may go to MET. From MET, you may go to RET and BRAF, and so on and so forth. And you and I all know that that's not enough DNA. So by the time you maybe not even completed an EGFR, you can't run it out because there is a shortage of tumor preservation. So in NGS, in 20 nanograms, you are able to run for multiple genes, get a target, hopefully get a target for your patient, and start the patient on targeted therapy. And in addition to that, the turnaround time is much shorter. And the most important fact for me, and I think for me as a clinical geneticist, is that you have the potential to discover novel actionable mutations. Remember I said in the realm, like if you're looking at, let's say, EGFR, we're limiting ourselves to 18, 19, 20, 21 exon, whereas in some other exon could be lying a potentially targeted mutation. So in my humble opinion, I think in the case of lung cancer, the NSCLC type, NGS does look to be a reliable and a good platform. Next, please. And just as we were beginning to understand, targeted therapy and oncogenes and tumor suppressor genes and how do they work, who's the driver mutation, who is the passenger mutation, in comes in this new era of immunotherapy. Next, please. As per the Science journal, Immunotherapy and the Science Journal was a breakthrough of the year. This was back in 2017. And this revolutionized the way we treat some types of cancers. In particular, in 2017, it was in the realm of melanomas. And as we know today, it's making huge inroads in our patients with lung cancer. As we saw, PDL1 is a recommended biomarker on diagnosis and on progression for patients with NSCLC. So this is possibly some of the most long-term follow-up data that we have on a small group of patients. Yes, it is a small group of patients who were exposed to immunotherapy. And for many, many years ago, this was done in the US. Now, it is one of the first clinical trials where patients were given, this was in the case of melanomas, where patients were given a compound called nivolumab, and these patients who should have normally, based on the disease, passed on within 6 months of enrolling into the study, 4 years onwards, 20% of the patients are alive and are doing pretty well. Next, please. So how does immunotherapy work? So when a cancer cell is formed, it has an antigen on it, right? An abnormal piece of protein that gets picked up by APC, which is called antigen presenting cell, and presents to the T cell. The T cell is our immune system. It is the T cell's job to go and attack this foreign body. And this T cell and APC form what we call an immune synapse. Now, normally the T cell should say, hey, you're a foreigner, and go and attack it and kill the cell. But it does not do that because of the clonal analogy signal that is called, that's the relationship between these set of compounds, and it doesn't allow the cell to function normally. So essentially it is, it is the PDL1, which is on the surface of the cancer cell, that binds to either PD1 or CTL4 on the normal, on the healthy, on the T cells. And this binds, and this is why the signal gets cut off, and the T cell is not able to identify and say, hey, you're a foreigner. So what immunotherapy does is it goes and it comes to this particular junction where this bond is there, where this synapse is formed, and it goes and it breaks it, it disrupts it. So when it disrupts it, the relationship obviously gets broken, and it kind of swings the balance in favor of the T cell from being woken up and eventually killing off these tumor cells. Next, please. So what we see over here is the clones, and as you can see, there are a lot of drugs that are available. You've got, you've got different platforms. You've got the DACO and the Ventana platform. You've got different clones. You've got your 22C3. You've got your SP142, SP263, 288. And initially, when this all started off, immunotherapy, I remember my colleagues in pathology used to get very stressed out because it was so many molecules, so many antibodies, the drugs were different, there was utter confusion. And I think over a period of time, it's become pretty straightforward, pretty streamlined, thanks to all the keynote studies that have come in that have made it very, very easy for us to understand these particular, the clone and what is required in interpretation. So now in the realm of NSCLC, be it the 22C3 for Pembro, be it SP263, and SP142. In the case of NSCLC, when we are calling out a PDL1, and I'm not a pathologist, but I'm going to try and explain this, we are looking for something called the TPS score, which is your tumor proportion score. And what this essentially does is it looks at the percent of viable tumor cells showing partial or complete response of staining at any particular intensity. And based on this TPS score, based on the percentage that they have, these various immunotherapy drugs can be given. Now, what is very interesting, and we just spoke about this 2 days ago when we were having a review of what had happened back at ASCO, was that when patients undergo, especially in stage 3, they undergo radiation therapy, it actually potentiates the immune environment in patients who've undergone radiation therapy. So patients who have had that therapy, they would potentially respond pretty well to immunotherapy. So at that particular point, if a patient's undergone radiation therapy or a combination of chemotherapy and radiation therapy, it is advisable to go and have the patient screened and checked for PDL1. Now, they did this primarily on the SP263 for durvalumab, where if they had a score greater than 25%, the patient would respond well to this checkpoint inhibitor, which is your PDL1. So again, this is how we're evolving. I mean, I made these slides a couple of days ago, a couple of months ago, but it's just the thought that 3 days ago, we were just discussing as to how important PDL1 is becoming in the realm of NSCLC. Next, please. So I'm going to go to the not very popular tumor mutation burden. And yes, tumor mutation burden, there is the FDA approvals that says you can use it for any solid tumor type. And if we look at that waterfall plot, which I actually forgot to put here, but if you look at that waterfall plot, it really doesn't work best in the realm of NSCLC. However, I think that very, very slowly, maybe after we do some more clinical studies, we have some more data, who knows, TMB can be the next biomarker that could actually be of potential benefit to our patients with NSCLC. And so very quickly to explain to you is that tumor mutation burden is essentially you're calculating the mutations per megabase. And you look at what is very important to know is that if you are sending TMB, let's say for any other cancer type, please ensure that a minimum of 250 gene panel is used to look at the number of, is used to help call out a TMB. Anything less than 250, 300 is not a good platform to call or to calculate tumor mutation burden. So what they do over here is that they look at the number of genetic aberrations in the exonic region, exon meaning the coding region, and this gives you an indirect idea as to whether or not the tumor you are dealing with, it has a high neoantigen load or a low neoantigen load. And this is an indirect marker for what is the mutation burden. So if the mutation burden is high, that's a high level of neoantigens and in any of the given tumor cells, and higher the chance that the patient could possibly respond to immunotherapy. Next, please. And like I said, in the realm of immunotherapy, we are continuously evolving. We have PDL1, we have TMB, you've got TILs, you've got, next please. I mean, there is just so much that is happening. I mean, this is something that is continuously evolving. So I'm obviously going to look forward to Who knows, in a month or 2 months, I'm going to be presenting something completely different for immunotherapy. Next, please. Oh, sorry, this is right. This is the right one. So again, over here, if you see, these are the different drug therapies, and look how everything has changed. We can give chemotherapy. You've got your NIBS, which is your molecular targeted therapy. You've got your immunotherapy, and you can do a combination of these therapies. You can do chemo with your NIBS, or you can do chemo with immunotherapy. There are just so many options available today when a patient presents in your clinic with NSCLC. Next, please. So this is just very quickly a flow chart as to, based on the NCCN guidelines, but next, please. This is my main slide. So these are your biomarkers for consideration for therapy in advanced NSCLC. Next, please. And what this does is, this actually allows us to divide our tumors into what I like to call the beginner's guide to drug therapy, which are those that are oncogene addicted. And you need to know what the mutations are and with what drugs. So as long as they're molecularly matched, they're going to do phenomenally well. And then you have those that it honestly doesn't matter what the mutation is, they are addicted to immunotherapy. And interestingly enough, next please. When you get it right, it works wonders. So what I have over here is the patient, a young, I think she was in her 50s, and she was non-smoker. She was diagnosed with EGFR L858R mutation. And when she came into the clinic, she was, she couldn't climb the stairs. She was continuously tired. Very poor quality of life. She was put on Geftinib, and it is phenomenal. And as you can see over here, there is a remarkable response to Geftinib. And she obviously came back to the clinic stating how she felt so much better. She could climb stairs. She could just go around, she could go putzing around doing her, going on with her daily business. And she did phenomenally well for 2.5 years. And then she came back to our clinic, and again, she presented with, we saw that there was a progression. We went in, we did a rebiopsy. We saw that she had a T790M. Again, we gave her a drug, and I know she's currently on osimertinib. And it's like I said, that, it's all about, you biopsy, molecular profiling, targeted therapy if available, patient progresses, and you go back and you repeat the cycle. So while, yes, it may not be curative, I think it is very, very effective. Next, please. So to very quickly, to summarize all that I've said, is that, yes, I do feel that in today's day and age, NGS is excellent platform for us, to help guide patient care, especially with the, with targeted therapy. I recommend molecular profiling, not the large ones up front, but when someone's newly diagnosed, at least for the sheer basic ones, your EGFR, ALK, ROS1, BRAF, MET. I would like to do it up front as soon as a patient is diagnosed, just so that I'm covering all my bases and I can give a more educated answer as to how I want to treat the, how I want to treat my patient and plan accordingly. And most importantly of all, there was always trepidation and fear that if I'm going to do fusions, can NGS catch it? I think today, 10 years, 12 years, having NGS as part of the, in our clinical practice, there's enough concordance data between the standard of care and next generation sequencing. And more importantly, next generation sequencing is starting to catch many more actionable therapies, which our standard of care are tending to missing out. And next, please. On that note, I am open to take any questions. Thank you so much for your kind consideration and for listening. Thank you.
Wonderful, Dr. Aparna.
Thank you.
A couple of questions are already waiting for you.
Okay.
Yeah, it was interesting.
Thank you. Thank you.
Let me start with Dr. Vishnu Harilal. Is trastuzumab approved in lung cancer? And please discuss kindly on mutual exclusiveness of driver mutations.
Two very good questions. Very, very good questions. And I actually omitted speaking on that for a reason. And one of the main reasons is that there used to be a time when we used to say that EGFR, ALK, ROS, they're not mutually exclusive. They are mutually exclusive, my apologies. And what we are starting to see today, not only in our databases, but in a lot of other labs, where we are starting to see patients who are presenting with EGFR and are having an ALK mutation. So it is changing, it is evolving. And a year ago, I would have said that they were exclusive, you would not see them together. But I'm starting to see them together. I think the only oddball in all of this is KRAS, that if you have a KRAS mutation, I'm yet to see KRAS with anything, any of the other driver mutations. So this is the current theme that we are seeing in our clinical practice. To answer your question on trastuzumab, as far as my knowledge goes, I think it is not just trastuzumab, it's adatrastuzumab, right? It is a TDM, if I'm not mistaken, that is approved for lung cancer. And again, it's not approved, it's work in progress, but it is a push come to shove. You can give the patient, you can treat him based on his HER2 mutation. So I hope that answers your questions.
The next question is, any predictor for sensitivity or success of CTC?
Oh, that is interesting. So we did recently, so there's no predictor per se. It is very difficult establishing it. When you talk about sensitivity and specificity, I think it boils down to, and you're talking about circulating tumor cells, which is very different. You're looking at the cell, the intact tumor cell. With respect to sensitivity and specificity, I think it is work in progress. I think there are only two platforms per se that I think have a good, I'm not sure on their validity, so I don't want to comment on it. I do know one's validity, but I'm not sure how much I'm supposed to disclose. So you've got the CellSeq, which I think is with Quest. CellSearch, sorry, which is with Quest, and the other one is with a company called OncoDiscover in India. And I think these are the only two platforms that are available which has excellent sensitivity and specificity in calling out circulating tumor cells. I do know the Indian version is cheaper and it is approved by DCGI. So, and they have some phenomenal data in the area of head and neck cancers. So again, CTC is very upcoming. It is essential. I think it's slowly going to make its way into clinical practice once we understand how to report and how to, what is a clinical concordance? How do we correlate between clinical and so, but it is a good question. We still need to figure out guidelines. AMP or CAP have not come out with guidelines saying that this is how you call it out. So I would depend on these two platforms right now.
Yeah, one very common confusion is the term platform. What do you mean by platform?
By platform, it's just me trying to sound very fancy and say the different type of techniques.
What is platform?
By platform, I'm basically just talking about which company are you using. In the realm, if I'm talking about NGS, then it's about which brand am I using? Am I using Thermo Fisher or am I using Illumina? So that's what I mean by platform. That is their approved, their validated machine that is available for sequencing. So that's why we call them different platforms. It's essentially doing the same thing. The workflow is exactly the same. I think only in the sequencer, there are these minute differences where one uses oligo beads, and while as the other one uses what we call a well system, where they develop this beautiful bridge method, which is I think Illumina. So they do have these different ways of the processes, but the end result is exactly the same. That's what I mean by platform in NGS.
What is the panel used in metastatic squamous cell carcinoma, and what are the clinical relevance?
So in the case of squamous cell, today we only have, which is which is in the guidelines per se, is EGFR, ALK, ROS, and PD-L1. Apart from this, we don't have any other oncogenes that we can use which has any actionability as per the guidelines. Over and above, I think we all are free to use this NTRK, which is an agnostic marker, which I do know a couple of physicians are using in the case of squamous cell. But if I have to stick to the guidelines, these are the only recommended ones by NCCN.
Yeah, the next one from Dr. Devanjan Kundu. In a cost-constrained setting, in EGFR, what are the mutations we must look for, like T790M always, or in metastatic adenocarcinoma only?
I would start looking for it. I think if you have a cost constraint, then yes, it is very logical to look at the exon 18, 19, 20, 21. I think that is the sheer minimum one should do. So be it the T790M or the 797SP, any of these mutations, they all are covered within these exons. So I do think that bare minimum cost is a concern, then one should opt that. At least do that using real-time PCR.
Thank you. Next question is from Dr. Manoj Jain. Best TKI treatment for adenocarcinoma with brain mets?
Okay, interesting. If it's an EGFR, I know I just heard this the other day. I'm not an oncologist, so I'm giving that as a heads up. I'm not an oncologist. But I think osimertinib, because I think it's able to cross the blood-brain barrier. I think Dr. Dodal will be the right person.
Well, I primarily, I'm taking care of the radiation part. I really do not practice any systemic treatment or immunotherapy, but yes, osimertinib is the one which can cross the blood-brain barrier, and there is
lectinib, I think. For ALK,
I know about osimertinib because that's a threat to me. Now there are a lot of studies going on to replace radiation in brain mets by osimertinib. So, you know.
And I think in the realm of ALK, it would be alectinib, if I'm not mistaken. Novartis is alectinib. I think they're the ones.
And the next one is in today's era in India, considering the cost effectiveness, what are the driver mutation tests that you would recommend from NGS apart from the usual EGFR, ALK, ROS1, and PDL1?
I would put in MET. I think MET is very important. I think TP53, I think NTRK, NTRK. I think these MET, even RET mutation, because we have targeted therapy, I think these should be added to the gene list along with KRAS.
Yeah. The next question from Dr. Rajit Ratan. Are you working on interpreting the data for community oncologists, and how do we use all the information of mutation lying in front of us? Most of the time, it becomes difficult in view of the increasing number of mutations and their interdependencies. So I think
I hear you.
Just a couple of days back, I was discussing with our medical oncologist also that this NGS report looks like a jargon sometimes. And then how to interpret, what are their clinical relevance? I think someone just pointed out the same thing.
Right. No, that's very true. It's very true. So I don't do the variant calling, which is the bioinformatics part. So what I do is I get the final report and I help interpret it as in how would you apply it in a clinical setup in your, how would you apply it with your patients? And there are a couple of things that I like looking at. One is a clinical correlation is very, very important with the genetic mutations. And I think in that, what we try and look for is you want to look for the variant allele frequency. You want to see that helps define which is your driver mutation and which is your passenger mutation. Also in the case when you start seeing two oncogenes like ALK and EGFR coming together, it helps define as to which particular gene, which gene is actually causing the disease at that time. So in cases like this, when you have multiple genes, you sometimes have even a TP53 or you have an RB1, you have a SMAD4. All these genes, when we start seeing that, they, like I said, they may not be actionable, but they do have some clinical correlation. And I'd like to say it's very important having a clinical oncologist or a genetic counselor, or a geneticist, or somebody on board who can help walk you through those reports. And that's what I tend to do. I tend to sync up with the oncologists and, for those who do have queries and help walk them through. And yes, you are right. Sometimes for us also, and especially when we do these comprehensive genome panels, these large panels, and we get so many mutations and we don't know what to do. So I think in times like that, yes, I do think it's important to have a geneticist to help guide you. And eventually at the end of the day, it is the doctor's call what they do for their patient, but a little help from here is always, we're always happy to help.
Thank you so much. I think this is the last question we're going to take from this session is, in your practice, are you running target mutation testing in stage 3 non-small cell lung cancer? Yeah.
We are starting to see patients coming in. I don't have the data for it. I am starting to see oncologists sending in at stage 3, but they're usually stage 3B and C. It doesn't come at stage 3A. I've had maybe 1 or 2 come in for PDL1, but otherwise, no, I have not seen any other, I've not had any nothing for stage 3A, primarily 3B and 3C. Yes, I do tend to see patients coming in. No one waits for stage 4 anymore.
There was one question I missed, an interesting question. Is Core involved in some kind of philanthropy, charity for needy patients?
I can tell you we have a tie-up with Novartis, which offers next-generation sequencing, which is looking at all these key mutations in the shortest turnaround time at a very low rate. So that is one thing that I know is available. Apart from that, I do know we have a core, like a social services group, but I am not the right person to comment as to what we offer. So I'm not really sure. We do have a CSR department, but I'm not really sure what we offer and what we can't offer. So I don't want to just make a promise, but I know Novartis is there for helping patients.
And I know for needy patients, there are always people who can go a little bit extra miles, who can walk that extra miles to get the benefit.
Right.
It always depends on the kind of interaction and kind of association you have with the physician and with the biomolecular biologist and with the team.
Exactly.
It's always like a team. So I think we should end here, and I must thank you for this excellent talk.
Thank you. Thank you for having me, and thank you everyone for staying on during dinner time. I do appreciate it.
Good night. Good night, everyone.
All right. Thank you very much. Thank you. Good night.